Hi, the history and clinical examination form the cornerstone of flexor tendon surgery. The what is to be done and how is it to be done are decided just by a good history and a thorough clinical examination. Though the clinical examination basically concentrates on establishing the integrity and function of the flexor tendons, it may have to be done in different situations. It may need to be done in the case of an acute injury of the flexor tendons, or in a delayed presentation of a patient with flexor tendon injury, or even after a flexor repair and reconstruction. All these aspects are dealt with in this video. A brief discussion about the investigations that can add to or confirm the clinical diagnosis is also included in this video. Though the basic aim is to assess the integrity and function of the flexor tendon, the priorities and the modalities of examination differ in different stages. Like for instance, after injury, we call it the acute phase, after injury in the cases of delayed presentation, or after repair or reconstruction. And in this video, we shall also be talking about the relevant investigations and the basic interpretation of these investigations. In the situation of examination of flexor tendons in an acute injury, there are three things to be recorded. One, the vital data, the history, and the clinical examination. First, let us see the vital data that are to be recorded, not only for documentation purposes but also for medico-legal purposes. The first is the general condition of the patient. This should first be stabilized before any examination on the hand is to be conducted. The age of the patient, the sex of the patient, the hand involved, whether dominant or non-dominant, the occupation of the patient, and the educational status must be recorded. The educational status is being recorded for trying to understand what would be his compliance and his understanding of the need for physiotherapy. Once the vital data have been recorded, the history must be elicited. The mode of injury, type of injury, duration since injury, and the position of hand at the time of injury should be ascertained. The mode of injury could be industrial, a road traffic accident, assault, or self-inflicted wound. The difference is that the first two, that is the industrial or road traffic accidents, may be associated with more skin lacerations and injury than the patients who have sustained an assault or a self-inflicted wound. The next point to be ascertained is whether the injury has been an open wound, a closed wound, or has been a spontaneous one, like the rupture that occurs in rheumatoid arthritis or tuberculous lesion, or in conditions like the Manifest lesion. Recording the time since the injury is also important because primary repair can be done in patients who have sustained an injury within the last 24 hours. But if it has gone beyond 24 hours, delayed primary repair can be done and secondary reconstruction is possible after 3 weeks. Sometimes it may be possible to get a history of the position of the fingers at the time of injury. This has a bearing upon what would be the position of the cut tendons in the wound. If the finger that sustained the injury, as represented by the blue arrow, was in flexion at the time of injury, the distal cut end of the flexor tendon would retract distally when the finger extends. This means that even on attempted extreme flexion of the distal portion of the finger, the cut distal end of the tendon would barely be visible at the wound. But if the finger was cut in a position of extension, on flexion of the distal portion of the finger, the tendon would easily glide into the wound, as demonstrated in the video. Having elicited a history with points relevant to flexor tendon injury apart from the routine history, we shall now see the clinical examination that must be conducted for such patients who have sustained flexor tendon injuries. The first step is to record the nature and site of the skin wound. Clean incised wounds like this are not a problem, and even crushed wound edges are not a problem. But when there are avulsed skin flaps, they may cause problems of healing later. Skin loss may also be present in some situations, and that should also be recorded. The next point is to note the position or the site of the injury. The wound may be at the level of zone 1, zone 2, zone 3, zone 4 or zone 5. However, it must be remembered that the site of injury on the skin does not determine the zone of injury on the flexor tendon. The wound may be on the palm, but that injury to the tendon may be in zone 2. The next points to assess are the associated injuries like vascular injury and vascular compromise to the hand or injury to the adjoining nerves. Just looking at the patient with an injury to the flexor tendons may give an idea that the flexor tendons have been injured from the very appearance of the attitude of the fingers, that is, the loss of the normal flexion cascade of the fingers. But still, we have to examine every single muscle and tendon before coming to the complete diagnosis. Before going into understanding the examination of the individual tendons, I shall be showing this green to denote normal function of the tested tendon and red to show the tendons that are not acting. First, we shall see the method of testing the FDS of the fingers individually. To check the FDS of the finger, we know that we need to check the flexion at the PIP joint. But the PIP joint is acted upon not only by the FDS but also by the FDP. So we need to prevent the action of the FDP while checking the FDS of the individual finger. Here we need to remember that the FDP of the middle, ring and little fingers have tendons that act together. So if we immobilize the ring and little fingers, the FDP of the middle finger is also immobilized. So when we ask the patient to flex the middle finger, he is using only the FDS and thus the FDS of the mid finger can be checked. Similarly, the FDS of the other fingers also can be checked. That is the ring finger and the little finger. The ring finger FDS is checked by immobilizing the middle and little fingers, and the little finger FDS is checked by immobilizing the middle and ring fingers. While doing this test for the middle, ring and little fingers, we must remember that after the patient flexes the finger, we must check the tone of the DIP joint. If it is tight, it means that patient is somehow using his FDP to flex the finger. The FDS of the index finger cannot be checked by this method because the FDP of the index finger is a separate entity and can act independently. There are two ways of checking the FDS of the index finger. In the first technique, the patient keeps his hand on the flat surface and then is asked to flex only the PIP joint of the index finger. The examiner now checks the tone of the DIP joint and makes sure it is lax. In this situation, it is the FDS of the finger that is acting. The second method is to ask the patient to do a forced pulp to pulp pinch between the thumb and the index finger. If the FDS is not acting, patient will not be able to do this and the finger will collapse. This shows a high median nerve palsy where the FDS of the middle, ring and little fingers are not acting. So the hand tries to do a tenodesis effect by hyperextending the metacarpophalangeal joint and trying to flex the finger, but it is only the FDP that is acting in all the three fingers. The action of the FDP is to flex the distal interphalangeal joint of the fingers. The middle phalanx of the finger is stabilized and the patient is asked to flex the distal interphalangeal joint. At the same time, the tone of the joint is now checked to make sure it is the FDP of the finger that is acting. In a situation where the FDP is paralyzed but the FDS of the index finger is intact, as in anterior intraosseous nerve syndrome, patient is asked to make an O with the index and the thumb. Patient will not be able to do this because the FDP of the index finger is not acting. Similarly, the FDP of the middle, ring and little fingers can be tested by stabilizing the middle phalangeal region. But it is important to check the tone of the DIP joint of the finger when this test is done. The flexor pollicis longus, which acts by flexing the interphalangeal joint of the thumb, is tested by stabilizing the proximal phalangeal region and asking the patient to flex the interphalangeal joint. The wrist flexors are tested by asking the patient to flex the wrist against resistance. When the patient does this, we need to palpate the three tendons, that is the flexor carpi radialis, the palmaris longus and the flexor carpi ulnaris when this movement is done. In this patient, the flexor carpi radialis, palmaris longus and FCU can be palpated on the right hand, but on the left hand only the flexor carpi ulnaris can be palpated. Under the same method of examination, when there is a partial injury to the tendons, there will be weak movements and the movements will be painful either on flexion or the antagonistic motion of extension. There are two other tests to test the integrity of the flexor tendons of the fingers, the tenodesis effect and the squeeze test. When we squeeze the distal part of the forearm in the resting position of the hand, the intact flexors will cause the fingers to flex. When the wrist is passively extended, the intact flexors will cause the fingers to flex further, and when the wrist is passively flexed, the extensors will cause the extension of the MCP joints of the fingers. But in the finger where the flexor has been injured, this extension of the fingers will be accentuated in that particular finger alone. If patients do not present within the first 24 hours following injury, we call it a late presentation because the treatment protocols become different and primary repair of the tendon may not be possible. The late presentation can be either after the injury, that is after 24 hours, presentation after 3 weeks and presentation after 3 months. Each of these categories has specific parameters to see in the examination and we shall see them one by one. When a patient presents after 24 hours but before 3 weeks, our aim would be to see if he will be amenable for a delayed primary repair which can be done up to 3 weeks. So the aim in the clinical examination would be to test the flexors to look for the suture line status, that is if the wound has already been sutured elsewhere, if the wound has not been sutured, what is the status of the wound, and if there is a skin loss, what is the area of skin loss and nature and the plan to reconstruct it and any associated injuries that need to be addressed. For example, this patient who has had a sutured wound on the palm and a flexor tendon injury of the right hand mid finger has presented 48 hours after the injury. The suture line appears clean, so we can plan for the delayed primary repair of the flexor tendons at the end of 2 weeks. It is not ideal to suture these wounds immediately as the primary phase of repair has passed and the status of the wound is still unknown. If the patient presents after 3 weeks, delayed primary repair is also not possible since the proximal cut ends would have retracted and only reconstruction will be possible. So all our examination methods will be aimed at planning the reconstruction and planning the time of the reconstruction. Here, the priorities would be to test the flexors, to test the passive range of movements, since there may be some stiffness in the intervening 3 weeks since the injury. We then need to look for signs of inflammation like edema and induration, which will postpone the plan of management of such presentations. We need to look for suppleness of the skin, of the scars that may be present and the joints before we plan for any reconstruction. For example, this patient sustained an injury 1 month ago and he is presented with a scar and inability to flex the finger. So obviously he has a flexor tendon injury, but on examination of the passive range, it is found that there is a stiffness at the proximal interphalangeal joint. When patients present after 3 months, there are many other problems that creep in. We test for the flexors, but we also need to check the passive range of movements as joint stiffness is a very common problem. We need to check the suppleness of the skin or the flaps that have been applied, and we need to check for associated injuries. The grading system for such chronic flexor tendon injuries is the Boyce and Stark grading system, where grade 1 is good, where there is only a tendon injury and the scars are supple. Grade 2, there is a scar. Grade 3, joints are stiff more than 10 degrees of stiffness, makes it grade 3. Grade 4, where the nerve and artery may be associated. And grade 5, multiple factors. like this patient with a loss of supple skin, loss of flexor tendons, loss of nerves and loss of passive joint mobility coming under grade 5. The examination after repair or reconstruction of flexor tendons is also important. The aim here would be to analyze the result of the repair and to plan for corrective surgery in case of unfavorable results. The movements at the individual joints achieved by the repair must be recorded accurately, as in this patient who sustained an injury to the zone 2 flexors of the index finger. The specific parameters to be noted are the power of the muscle, the active range of movements, the passive range of movements, and these movements must be recorded in the individual joints, the metacarpophalangeal joint, the proximal interphalangeal joint and the distal interphalangeal joints. These recordings must be made serially to note the progress or lack of it. The significance of these recordings are to plan for management according to the findings and to plan the management protocol. If the active range is 0 and the passive range is 0, there is a problem in the joint and it requires a joint release. Like in this patient who presented 3 months after a flexor tendon repair and has not undergone any physiotherapy. This column is not possible because we cannot have an active range without a passive range. When there is no active range but there is a minimal passive range, it needs therapy to improve the passive range and exercises to improve the active range, and the same therapy is required when the active range is minimal and the passive range is also minimal. Like in this patient who has had an FDP reconstruction after a FDP avulsion following a cracker burst injury. If there is no active range of movement but the passive range has become full, it needs tendon reconstruction again, as the repaired or reconstructed tendon is not working. However, if the passive range is full but there is a minimal active range, it means that there are adhesions or the pulleys are deficient. So it needs flexor tenodesis or pulley reconstruction. As in this patient who had a full passive range but reduced active range, she was found to have adhesions on exploration. Now we shall see the basic investigations that can be done for a patient with a flexor tendon injury and how to interpret the results of these investigations. Plain radiographs will show concomitant fractures, avulsion fractures along with tendon injuries, and the soft tissue shadow showing the injury. The underlying fractures, such as the fracture of the base of the proximal phalanx or the neck of the proximal phalanx, can be noted. Fractures of the forearm bones also can be noted in some patients with flexor tendon injuries, and it is important to treat these fractures and stabilize the skeleton before the flexor tendon injuries can be repaired. In the case of the jersey finger, there is an FDP avulsion, and the position of the bone fragment, if it has been avulsed along with the tendon, will give us an idea about the position of the tendon. The fracture fragment at the level of the DAP joint shows the Leddy-Packer type 3 FDP avulsion, and the small fracture fragment that can be seen at the level of the middle phalanx denotes the type 4 FDP avulsion. The next modality that can be used is the ultrasound. The longitudinal or transverse ultrasound scan can be used, and the tendons appear as hyperechoic fibrillar structures. To differentiate the FDS and the FDP, the anatomical position can be used, or dynamic examination by selective movements of the finger joints can denote the difference between the FDS and FDP. This longitudinal scan shows the position of the FDS and FDP in relation to the metacarpal head. This ultrasound picture shows the position of the FDP and FDS where the slips of the FDS have divided. This picture shows the insertion of the FDP tendon and its relation to the volar plate of the DIP joint. Apart from visualizing the flexor tendons, the annular pulleys also can be analyzed, especially with the high resolution ultrasound. They appear as thin anisotropic bands over the flexor tendons on transverse scans. The volar portion appears hyperechoic, whereas the lateral portion of the annular pulleys appears hypoechoic. Dynamic scanning can be done to distinguish the fixed pulley system from the gliding flexor tendons. This ultrasound picture shows the important A2 annular pulley. So the indications for ultrasound in a case of flexor tendon injury can be to document the injury to the tendon gap can be measured, the integrity of the pulleys can be assessed, the tendon bone distance can be measured. This will help us to measure the bowstringing, and dynamic scanning can be done for assessment after repair. The third important investigation that can be done is the MRI, which can show sagittal and axial images. The MRI can visualize normal tendon, which appears as low signal intensity on all pulse sequences. We can also visualize the annular pulleys on the sagittal and axial views. Specifically, MRI can differentiate low grade from high-grade partial tears and complete ruptures of flexor tendons. In partial injuries, axial images can show us exactly the amount of tendon that has been disrupted. And in complete injuries, MRI can accurately determine the extent of the tendon retraction. There are two types of images on MRI, the T1 weighted images, which allow a detailed evaluation of the anatomy, and the T2 weighted images which delineate the fluid-filled partial or complete tendon defects. This MRI image shows a T2 weighted sagittal image showing the zone 3 laceration of FDS and FDP of the index finger, and the exact gap is shown between the two cut ends. And this T1 weighted sagittal image shows a disruption of the distal FDP tendon. So the ideal indication for MRI in a case of flexor tendon injury would be to differentiate partial and complete injury to the tendons, evaluate the extent of partial tear, and evaluate the gap between the cut ends in a complete tear. I hope you liked the video. Please click on the following links to see more about flexor tendon repair and reconstruction. And do not forget to subscribe to keep updated with the latest in learning hand surgery.